So good morning, dear students. So today we'll be discussing the second part of this topic, that is elimination of nitrogenous waste, the excretion and elimination of nitrogenous waste. So we'll be discussing about the formation of urine. You just have to recollect, in the previous class we had discussed about the structure of nephron. See, nephron has a glomerulus, which has a Bowman's capsule and a network of the capillaries, which we call it as glomerulus, that is the renal corpuscle. Then we have the renal tubules, which starts with the proximal convoluted tubule. It proceeds to the Henle's loop, distal convoluted tubule, and to the collecting duct. So we have all these uh, in the structure of a nephron. See, the structural and functional unit of kidneys are nephrons. And I had also discussed about two types of nephrons. So the juxtamedullary nephrons and cortical nephrons. So they are just in the cortical region. So near most of them are the cortical nephrons that we had. So cortical nephrons are 85% of them are in the cortex zones. They have a small Henle's loop, whereas the juxtamedullary nephrons, which are 50%, so the Henle's loop is very long and runs deep into the medulla. So vasa recta, that is the capillary of blood vessels, so they are present. Okay, so let us proceed with the next important step, that is the formation of urine. So this is the physiology of kidney. So during the process of formation of urine, there will be the elimination of nitrogenous waste like urea. I had already told you that the toxic ammonia is taken into the liver and they are converted into non-toxic form, that is urea, during the process of ornithine cycle. So that we had discussed in the previous class. So there are three steps in the formation of urine. So the glomerular filtration, tubular secretion, and tubular reabsorption. So those three steps are involved in the process of formation of urine. So let us understand about them. So there are three steps involved in the process of urine formation. So one is the glomerular filtration. So you should understand that the arteries here, they are the afferent arteriole where the blood is entering into, and efferent arteriole where the blood is taken out. So afferent and efferent arterioles are there in this glomerulus, and the diameter also varies. Okay, so the first step in the process of formation of urine is glomerular filtration within the glomerulus, so which is enclosed by this Bowman's capsule. Then there is tubular reabsorption and tubular secretion. So these are the other steps that are taking place during the process of formation of urine. So for 5 marks, they might ask you any of these steps or complete detail of it. So you should be in a position to explain this. So all these diagrams are purely for explanatory purpose. They are not required for your examination. So they are for explanatory purposes. Okay. So the glomerular capillary blood pressure causes filtration of blood through three layers. So the glomerular capillary blood pressure. So the blood pressure of the glomerular capillary blood pressure, they causes filtration of blood through three layers. One is endothelium of glomerular blood vessels. So the outermost squamous epithelium, the innermost squamous epithelium covering the blood capillaries, we call it as endothelium. So the endothelium of glomerular blood vessels, epithelium of Bowman's capsules, basement membrane between these two uh, layers. So they are all responsible for the glomerular capillary blood pressure. They causes filtration at three layers. Filtration of blood through three layers. One is the endothelium of glomerular uh, blood capillaries. Okay. The second one is the epithelium of Bowman's capsule. Third one is the basement membrane between these two layers. So they are going to cause filtration of blood, majorly because of the blood pressure of the glomerular capillary blood pressure. It causes filtration of blood through three layers: endothelium of the glomerular blood vessel. Then there is the epithelium of Bowman's capsule. So glomerular blood vessel, Bowman's capsule epithelium, then the basement membrane between these two layers. So these are the three layers at which the filtration of blood takes place because of glomerular capillary blood pressure. So this three you have to understand about this. So epithelial cells, they have this podocyte. So epithelial cells, podocytes of the Bowman capsule, are arranged in an intricate manner. So epithelial cells or podocytes of the Bowman's capsule, they are arranged in an intricate manner, leaving some minute spaces called filtration slits. Okay, so the epithelial cells or podocytes of the Bowman's capsules are arranged in an intricate manner so that uh, they leave some minute spaces called filtration slits or slit pores. Okay, so that is what you notice in the epithelial cells of the Bowman's capsule. They are arranged in an intricate manner so that they give this the filtrate slits. Can you notice this spaces? So epithelial cells of the Bowman's capsules are arranged in an intricate manner, leaving some minute spaces. So these are the minute spaces that they are leaving so that there is, we call that as filtration slit or slit pores. So here you can notice this filtration slit. So the epithelial cells of the Bowman's capsules are arranged in an intricate manner, leaving some minute spaces called filtration slits or filtration pores. Okay. So almost all constituents, see here, this is the glomerulus. Almost all constituents of blood plasma, the blood is passing through the glomerulus. You know that almost all constituents of this blood plasma of the blood in the glomerulus, except the proteins, okay, they pass on to the lumen of Bowman's capsule. All the constituents of plasma, except the proteins, they pass into the lumen. This is the space, lumen of Bowman's capsule. Okay, so about 110 100 to 1200 ml of blood is filtered by kidneys per minute. So all the constituents of blood plasma, except the proteins, pass on to the lumen of Bowman's capsule. So about 1100 to 1200 ml of blood is filtered by kidneys per minute. It constitutes one fifth of the blood pumped out by each ventricle of the heart in a minute. So it constitutes one fifth of the blood pumped out by each ventricle of the heart in a minute. So, so much of blood is being filtered by the kidneys. So 1100 to 1200 ml of blood is filtered by kidneys per minute. It constitutes one fifth of the, that is one part of five. Total, if you divide the blood into five parts of it, it is almost 1 liter of 5 liters of the blood pumped out by each ventricle of the heart in a minute. So one fifth of the blood pumped out by each ventricle of the heart in a minute. So much of filtration is taking place within this uh, glomerulus and the Bowman's capsule. All the constituents of blood plasma, except the proteins, they pass into the lumen of Bowman's capsule. So you can see the afferent arteriole with larger uh, diameter and efferent arteriole with smaller diameter. This itself creates that glomerular capillary blood pressure is created by the difference of these diameters. So the afferent arteriole through which the blood enters, and they are going to be filtered. So through these, the all the constituents of the plasma enters into the Bowman's capsule, except proteins, and this filtered blood is then passed out through the efferent arteriole. Okay. The amount of glomerular filtrate formed per minute is called glomerular filtration rate. The amount of glomerular filtrate formed per minute, okay, the amount of glomerular filtrate formed per minute, so we call it as glomerular filtration rate, GFR. So the normal glomerular filtration rate is equal to 125 ml per minute, that is 180 liters per day, 125 ml per minute. The amount of glomerular filtrate formed per unit per minute, so the amount of glomerular filtrate formed per minute, we call it as glomerular filtration rate. So the normal glomerular filtration rate is 125 ml per minute, and in a day it would be 180 liters per day. So much of blood is being filtered by our kidneys. So 180 liters of glomerular uh, filtrate is produced per day. Okay, but 99% of this is reabsorbed by renal tubules. So normal volume of urine uh, released or thrown out is 1.5 liters. Even though there is 180 liters of glomerular filtrate is produced daily, 99% of them are reabsorbed by the renal tubules, that is at the proximal convoluted tubule, Henle's tubule, distal convoluted tubule. So there is 99% of them are reabsorbed. So the normal volume of urine released is only 1.5 liters. So from the filtrate, glucose, amino acids, sodium ions. So you can see here glucose, amino acids, sodium ions are reabsorbed actively, and nitrogenous waste are absorbed passively. Okay, so the glucose, amino acids, sodium ion, they are all reabsorbed actively. That means with expenditure of energy, and nitrogenous wastes are absorbed passively. So that is what you have to remember about. So passive reabsorption of water, they occur in the initial segment of the nephron. So the passive reabsorption of water occurs in the initial segment of the nephron. So that is the proximal convoluted tubule. So passive reabsorption of water takes place in the initial segments of the nephron, that is proximal convoluted tubule, descending loop. So they are all the places where there is reabsorption of passive reabsorption of water, which occurs in the initial segments of the nephron. So 180 liters of glomerular filtrate is produced daily, but 99% of them is reabsorbed by renal tubules. So 99% of them are reabsorbed by renal tubules. So normal volume of urine that is released is 1.5 liters. From the filtrate, glucose, amino acids, sodium ions, they are all reabsorbed actively. I just told you about all that. So they are reabsorbed actively. That means that uh, they are going to spend energy to absorb back the glucose, amino acids, sodium ions, and nitrogenous wastes are absorbed passively. So the passive reabsorption of water, they occur in the initial segments of the nephron. So the passive reabsorption of water occurs in the initial segments of the nephron. So proximal convoluted tubule, they reabsorb 70 to 80% of electrolytes and water, PCT, which is nearer to the Bowman's capsule. They reabsorb 70 to 80% of electrolytes, and water is reabsorbed by the proximal convoluted tubule. So this proximal convoluted tubule, they are made up of simple cuboidal brush border where they have this microvilli. So simple cuboidal brush border epithelium of PCT increases the surface area for reabsorption. Nearly 70 to 80% of water and electrolytes are reabsorbed in this zone, that is the proximal convoluted tubule. And the why that is happening is because this proximal convoluted tubule is made up of simple cuboidal brush border epithelium. they increase the surface area for reabsorption. That is the reason they are reabsorbing 70 to 80% of electrolytes and water at the PCT, proximal convoluted tubule. So the loop of Henle's loop, there is a descending limb, ascending limb, and then they enter into the distal convoluted tubule. So the loop of Henle, this entire part of it, they maintain high osmolarity. So osmolarity of medullary interstitial fluid. So this is the medullary interstitial fluid. So the cortical region, you find the Bowman's capsule, proximal convoluted tubule, distal convoluted tubule. But the Henle's loop is entering deep into the medulla. Okay, so the medullary region, they'll be having this interstitial fluid. So it maintains the high osmolarity of medullary fluid. So they maintain this high osmolarity of medullary fluid, medullary interstitial fluid. So the descending limb is permeable to water, but almost impermeable to electrolytes. So this concentrates the filtrate. So they are permeable to water. The descending limb is permeable to water. They allow the exit of water, but they are impermeable to electrolytes, and that leads to concentration of these filtrate. So the glomerular filtrate, it is also called as primary urine. So, okay, so that part of it you should also remember. So in the Henle's loop, so they are going to maintain high osmolarity of the medullary interstitial fluid. So the medullary interstitial fluid, they are going to maintain high osmolarity. So the descending limb of Henle's loop, it's highly permeable to water, but impermeable to electrolytes. So because of which there is a concentration of this filtrate. So in ascending limb, minimum reabsorption occurs. So there is minimum reabsorption in the ascending limb of Henle's loop, and it is impermeable to water. So they do not allow water to exit out, but allows transport of electrolytes. So it is completely opposite in function to that of the descending limb. The ascending limb is impermeable to water, so but almost permeable to electrolytes. So this concentrates the filtrate further. So in ascending limb, minimum reabsorption occurs. It is impermeable to water but allows transport of electrolyte. Again, the filtrate here gets diluted. In Henle's descending loop, the filtrate got concentrated. In the Henle's ascending loop, the filtrate gets diluted because it is impermeable to water, and the electrolytes are, it is permeable to. So the filtrate here in the ascending limb of Henle's loop, they get diluted. In distal convoluted tubule, so there is conditional reabsorption of sodium ion and water takes place. So there is a conditional reabsorption of sodium ion and water taking place in the distal convoluted tubule. So the collecting duct extends from cortex. See, they are found from the cortical region of kidney to the inner parts of medulla. So the collecting duct extends from cortex to the inner parts of medulla. So it reabsorbs large amount of water. So it reabsorbs large amount of water to concentrate urine. Okay, so it also allows passage of, so it reabsorbs large amount of water. So the collecting duct, uh, it is going to allow the reabsorption of water. So to concentrate urine, it also allows passage of small amount of urea into medullary interstitium to keep up the osmolarity. So very little amount of urea is also lost from this collecting duct to keep up the osmolarity of this interstitial fluid. So such interesting things are happening within the nephron, isn't it? So here you found that there is the proximal convoluted tubule, there was some reabsorption, and especially it is permeable to water and electrolytes. Okay, so the reabsorption was taking place. In the Henry's descending loop, it was only permeable to water but not for electrolytes. In the ascending loop of this Henry's loop, They were impermeable to water but permeable to electrolytes. So the dilute urine was formed. In the distal convoluted tubule, there is reabsorption of sodium ion and water taking place. So the collecting duct, which extends from cortex to the innermost part of medulla, so it reabsorbs large amount of water to concentrate the urine. It also allows passage of small amount of urea into medullary interstitium. So small amount of urea into the medullary interstitium to keep up the osmolarity. So that is what is being done here. So the final stage of formation of urine is tubular secretion. So the cells of proximal convoluted tubule and distant convoluted tubule. So the cells of PCT and DCT, that is proximal convoluted tubule and distal convoluted tubule, they maintain the sodium potassium ion balance and acid base balance, that is pH of body fluids, by selective secretion of protons, potassium ions, and ammonia into the filtrate and absorption of bicarbonate from it. So that is going to take place. So the cells of proximal convoluted tubule and distal convoluted tubule, they maintain ionic sodium potassium ion balance and acid base balance, that is pH of body fluids, by selective secretion of hydrogen ions, potassium ions, and ammonium ion into the filtrate and absorption of bicarbonate from it. So they not only maintain the ionic balance, that is sodium potassium balance, that is the cells of proximal convoluted tubule and distal convoluted tubule, but they also maintain the acid base balance, that is pH of body fluids, by selective secretion of the protons, potassium ions, and ammonia into the filtrate and absorption of bicarbonate from it. So this is how they are going to maintain the ionic balance as well as the acid base balance by selective secretion of uh, proton, the potassium ion and ammonia into the filtrate and reabsorption of bicarbonate from it. Okay. So collecting duct maintains pH and ionic balance of blood by the secretion of the proton and potassium ion. So they maintain the pH and ionic balance of blood by the secretion of proton and potassium ions. So this is the formation of urine at a glance. So there is the glomerular filtration. Nearly all the contents of the glomerular, the plasma of the blood is filtered at, into the Bowman's capsule, except for proteins. So this filtrate within this Bowman's capsule, we call it as primary urine. So this primary urine passes through this distal convoluted tubule where there is tubular uh, reabsorption taking place. So the water and electrolytes, nearly 70 to 80% of them are reabsorbed, especially because of this cells, cuboidal, simple cuboidal epithelial cells with brush border. They increase the surface area for absorption. So they reabsorb them. So the water and certain electrolytes. So some of them are reabsorbed actively, that is with expenditure of energy. So the water, glucose, they're all reabsorbed actively, and there are some which are reabsorbed passively. So then the filtrate, it passes through the descending limb of Henle's loop. So here they are impermeable to electrolytes but permeable to water. So water is secreted. So water is absorbed, tubular absorption. Then the filtrate, it again passes through the ascending limb, wherein you notice that there is they are impermeable to water but permeable to electrolytes. So there is a dilution of this filtrate and it enters into this distal convoluted tubule. So from the distal convoluted tubule, you notice that in the distal convoluted tubule, so conditional reabsorption of sodium ion and water takes place. So the collecting duct there is going to be reabsorption of large amount of water, and a little secretion of urea also takes place. So the concentration of this urine takes place. Okay, so this is how. Then there is a tubular secretion, so wherein the cells of proximal convoluted tubule and distal convoluted tubule, they are maintaining the ionic balance, that is sodium potassium balance, and the pH, acid base balance, that is pH of body fluids, by selectively secreting potassium ions, protons and ammonia into the filtrate, and absorbing the bicarbonates, that is HCO3 minus from it. So duct, collecting duct maintains pH and ionic balance of blood by the secretion of, see, the collecting duct also maintains pH and ionic balance of blood by secretion of the proton and potassium ions. So that is how they are going to maintain the uh, pH and ionic balance of blood. So the urine formation, the counter current system, that is the third part that we'll be studying at present. So the concentration of the filtrate that passes from the uh, glomerulus into the Bowman's capsule. So the Henle's loop and vasa recta is the capillary of blood surrounding this nephron. We call it as vasa recta. Henle's loop and vasa recta help to concentrate the urine. Okay, so they remove the water and help to concentrate the urine. So the flow of filtrate in the two limbs of Henle's loop and the flow of blood through the two limbs of vasa recta are in opposite directions. So the flow of filtrate in the two limbs of Henle's loop and the flow of blood through the uh, two limbs of vasa recta, so they are in opposite direction. The flow of blood will be in opposite direction. So that is in a counter current pattern. So this is called as counter current mechanism. So what is the counter current mechanism? So the flow of filtrate in the two limbs, here you can notice the flow of filtrate in the two limbs of Henle's loop and the flow of blood uh, through the two limbs of vasa recta, the flow of blood through the two limbs of vasa recta, they are in counter current. Okay, the flow of filtrate in the two limbs of Henle's loop and the flow of blood through the two limbs of vasa recta, they are in opposite direction. Here it is climbing up, here the blood is going down. So they are in opposite direction. Here it is climbing down, here it is going down. So we call this as this type of arrangement as counter current pattern. So this is called counter current mechanism. So the flow of filtrate in the two limbs, that is of Henle's loop, and the flow of blood through the two limbs of vasa recta. So you can see the flow of blood when the ascending limb, they are climbing up, the blood is climbing down. So they are in opposite direction, isn't it? So here when the ascending limb is flowing down, so the blood is climbing up. So they are in opposite direction. The flow of filtrate and the flow of blood through the two limbs of vasa recta, they are in opposite direction. So this is called counter current mechanism. So in a counter current pattern it is, this is called as counter current mechanism. So Henle's loop and vasa recta help to concentrate the urine. Due to the counter current and proximity between Henle's loop and vasa recta, osmolarity increases from cortex. So in the cortex, the osmolarity was 300 uh, microosmolarity per liter to the inner medullary interstitium. So the inner medullary interstitium, you find the osmolarity to be, so increases from the cortex to the inner medullary interstitium from 300 osmolarity, microosmolarity per liter to 1200 microosmolarity per liter in the medullary interstitium. So this gradient is caused by sodium chloride and urea. So due to the counter current and proximity between Henle's loop and vasa recta, so osmolarity increases from 300 microosmolarity per liter in the cortex to the inner medullary interstitium of 1200 microosmolarity per liter. So this gradient is caused because of the sodium chloride and urea. So this gradient or this difference is caused because of sodium chloride and urea. So this is what you have to remember regarding the concentration of the filtrate, wherein it is due to the counter current and proximity between Henle's loop and vasa recta. The osmolarity increases from the cortex, which was having 300 microosmolarity per liter. So it increases in the medullary interstitium to 1200 microosmolarity per liter. This gradient is caused by the sodium chloride and urea. So the sodium chloride is transported by ascending limb, of Henle's loop with descending limb of vasa recta. So the sodium chloride is transported by ascending limb of Henle's loop that is exchanged with descending limb of vasa recta. So the descending limb of vasa recta and the ascending limb of uh, the Henle's loop, the sodium chloride is transported. So sodium chloride is returned to interstitium by ascending limb of vasa recta. So the sodium chloride is returned to the interstitium by the ascending limb of vasa recta. So that is how it is taking place. So this counter current mechanism helps in the concentration of the filtrate. So sodium chloride is transported by the ascending limb of Henle's loop, which is exchanged with descending limb of vasa recta. So they are exchanged with descending limb of vasa recta. So sodium chloride is returned to the interstitium by ascending limb of vasa recta. So they are returned back to the interstitium by the ascending limb of vasa recta. So that is how they are. Sodium chloride is returned to the interstitium by the ascending limb of vasa recta. You can notice that they are liberating the sodium chloride. So they are going to be the ascending limb of vasa recta is going to return the sodium chloride to the interstitium by the ascending limb of vasa recta. Similarly, small amount of urea, I told you that small amount of urea enter the thin segment of the ascending limb of Henle's loop. So they are going to enter into the thin segment of the urea enter the thin segment of the ascending limb of Henle's loop, which is transported back to the interstitium by the collecting tubule. So small amount of urea enters into the ascending limb of Henle's loop, which is transported back to the interstitium by the collecting tubule. So that is what they are doing it. Okay, small amount of urea enter the thin segment of ascending limb of Henle's loop, so which is returned back to the interstitium by the collecting tubule. So that is being written back by the interstitium to the collecting tubule. Thus, electrolytes and urea are retained in the interstitium. So electrolytes and urea are retained in the interstitium and they maintain a concentration gradient, interstitial gradient in medullary interstitium. So the electrolytes and urea are retained in the interstitium and they maintain a concentration gradient. That is difference in concentration when compared to the cortical region and medullary region. There is a concentration gradient because of the electrolytes and urea being retained into the interstitium. So it enables easy passage of water from collecting tubule to concentrate the filtrate, that is the urine. So it allows the easy passage of water from collecting tubule. So to concentrate the filtrate. So this glomerular, this interstitial gradient in medullary interstitium, it enables easy passage of water from collecting tubule to concentrate the filtrate or urine. Thus, the distal convoluted tubule and collecting duct produce urine 4 times concentrated than the initial filtrate, that is 300 microosmolarity per liter to 1200 microosmolarity per liter. So much of concentrated, 4 times concentrated than the initial filtrate is formed at the distal convoluted tubule, and collecting duct produce urine 4 times concentrated than the initial filtrate formed, that is 300 microosmolarity per liter to, so initially it was 3000 microosmolarity per liter to presently it is 1200 microosmolarity per liter. So the urine has been concentrated 4 times more than the initial filtrate in the distal convoluted tubule and collecting duct. So micturition is the process of release of urine. So the steps involved in the process of release of urine are gradual filling up of urinary bladder. So the stretching of urinary bladder. So the stretch receptors in its wall send impulses to central nervous system. So the central nervous system receives the impulses. So the CNS passes on motor messages. So they pass on the motor message. So the contraction of smooth muscles of the bladder and simultaneous relaxation of urethral sphincter, it releases the urine. That is micturition. The process of passage of urine or release of urine, we call it as micturition. What are the steps involved in this is the gradual filling of urinary bladder, the stretching of urinary bladder takes place, the stretch receptors on its wall. So you can see the stretch receptors on its wall. It sends impulses to the central nervous system. So the central nervous system process that impulse and pass on motor message. So they are going to pass on the motor message. As a result of that, there is contraction of the smooth muscles. So what is going to happen in the urinary bladder is when they receive this motor message, there is contraction of smooth muscles of the bladder. They contract, and simultaneously there is relaxation of the urethral sphincter. So they are going to be relaxation of urethral sphincter and contraction of this urinary bladder muscles, smooth muscles of the bladder, and simultaneous relaxation of urethral sphincter. So there is internal sphincter, external sphincter. So there is a relaxation of the simultaneous relaxation of urethral sphincter, which releases, helps in the release of urine or the micturition process. So the urine passage of urine or the urination process is called as micturition. So the how is the exact process of micturition taking place? There is gradual filling up of urinary bladder. So the stretching of the urinary bladder. So the stretch receptors on its wall sends an impulse to central nervous system. So central nervous system passes on motor message, so which results in contraction of the smooth muscles of the bladder and simultaneous relaxation of urethral sphincters, both internal and external, and this results in the micturition or release of urine. So these are the steps involved in the urination process. So the neural mechanism, so which is causing this micturition is called micturition reflex. So the neural mechanism which causes this micturition or urination process is called as micturition reflex. So this mechanism is called as micturition reflex. So micturition, so the neural mechanism causing micturition is called as micturition reflex. An adult human excretes 1 to 1.5 liters of urine per day, and there will be 25 to 30 grams of urea thrown out from our body. So an adult human excretes 1 to 1.5 liters of urine per day, and 25 to 30 grams of urea is thrown out or removed from our body per day. So remember these facts. So urine is a light yellow colored watery fluid, slightly acidic, pH is 6, and has a characteristic odor. So urine is a light yellow colored watery fluid, slightly acidic, and pH slightly acidic, pH is 6 and has a characteristic odor. Okay. So the various conditions affect the characteristics of urine. So urine analysis helps in clinical diagnosis of many metabolic disorders and malfunctioning of the kidney. Example, glycosuria for presence of glucose and ketonuria, ketone bodies in urine indicates diabetes mellitus. So glycosuria, presence of glucose, and ketonuria, presence of ketones in urine indicates diabetes mellitus. Okay, so if there is a blue color when the Benedict's reagent is added to the urine, so there is no glucose. If there is green color, traces of glucose are there. If it is moderate amount of glucose, orange color, moderate amount of glucose is there. If it is brick red, large amount of glucose is present. So these are the indicators by Benedict's test. So the urine analysis helps in clinical diagnosis of many metabolic disorders and malfunctioning of the kidney. So glycosuria, the presence of glucose, and ketonuria, the ketone bodies in urine, they indicate diabetes mellitus. If urine consists of glucose and ketone bodies, it indicates diabetes mellitus. So glycosuria, ketonuria are uh, indicators of diabetes mellitus. So role of lungs, liver and skin in excretion. Lungs remove carbon dioxide 200 ml per minute and water. Okay, so the lungs are going to remove the waste, that is the carbon dioxide 200 ml per minute, and they are also going to remove water, carbon dioxide and water. Liver secretes bile containing bilirubin, biliverdin, cholesterol, degraded steroid hormones, vitamins, and drugs. Most of them pass out along with digestive waste. So the liver secretes bile juice, which contains bilirubin, biliverdin, cholesterol, degraded steroid hormones, vitamins, and drugs. So most of them pass out along with the digestive waste. The sweat contains water, sodium chloride, small amounts of urea, lactic acid, etc. So the sweat is going to contain water, sodium chloride, small amounts of urea, lactic acid, etc. The primary function of sweat is to give a cooling effect on body surface. So the sebaceous glands, they eliminate sterols, hydrocarbons, and waxes through sebum. So sebum provides a protective oil covering for the skin. So these are all the different organs which have a role in excretion. So skin, they are going to produce the sweat and sebaceous glands, the oily glands. So sweat contains, what does the sweat contain? Water, sodium chloride, small amount of urea, lactic acid, etc. So water, sodium chloride, small amount of urea, lactic acid, etc. The primary function of sweat is to give a cooling effect on body surface. The sebaceous glands, they eliminate sterols, hydrocarbons, and waxes through sebum. So they eliminate sterols, hydrocarbons, and waxes through sebum. Sebum provide a protective oily covering for the skin. So that is the role of this sebaceous glands, which eliminate sterols, waxes, and hydrocarbons through sebum. So sebum provides a protective oil covering for our skin. So saliva eliminates small amount of nitrogenous waste. So very small amount of nitrogenous waste. So the role of lungs removes the carbon dioxide 200 ml per minute. Liver is going to remove the bilirubin, biliverdin, cholesterol, steroids, the uh, various other components like steroidal hormones, vitamins, and drugs, uh, degraded steroidal hormones. Most of them pass out along with the uh, undigested food during the uh, as a fecal matter. So most of them pass out along with digestive waste. Sweat contains water, sodium chloride, small amount of urea, lactic acid, etc. The primary function of sweat is to give a cooling effect on body surface. So the sebaceous glands eliminate sterols, hydrocarbons, waxes through sebum. So sebum provides a protective oil covering for the skin. So the saliva eliminates small amount of nitrogenous waste. So the regulation of kidney function, the next part 4 topic under this excretory system is regulation of the kidney function. How is it being regulated? So the regulation, the control of the kidney function is done by hormonal feedback mechanism, and it involves the hypothalamus, uh, JGA, and heart. So juxtaglomerular apparatus and heart. So it is done by the hormonal feedback mechanisms involving the hypothalamus. So juxtaglomerular uh, uh, component and heart. So the changes in blood volume, body fluid volume, and ionic concentration, they activate the osmoreceptors in our body. So changes in blood volume, body fluid volume, and ionic concentration, they activate the osmoreceptors in our body. So once the osmoreceptors are activated, when body fluid level decreases, the osmoreceptors stimulate the hypothalamus to release antidiuretic hormone. So when the body fluid level decreases, the osmoreceptors stimulate the hypothalamus to release antidiuretic hormone ADH or vasopressin. It stimulates water reabsorption from distal convoluting tubule and collecting dust. Thus, ADH or antidiuretic hormone prevents diuresis and increases body fluid volume. So when body fluid level decreases, the osmoreceptors, they are going to stimulate the hypothalamus to release antidiuretic hormone ADH, or it is also called as vasopressin. So vasopressin, it stimulates water reabsorption from distal convoluted tubule, DCT, and collecting duct. Thus, ADH prevents diuresis and increases the body fluid volume. So increase in fluid volume, that is decrease in fluid volume. Increase in fluid volume switches off the osmoreceptors. It is an opposite effect and suppresses the ADH release to complete the feedback. So ADH constricts and suppresses the antidiuretic hormone release to complete the feedback. So ADH constricts blood vessels, resulting in an increase of BP. So this increases the glomerular blood flow and glomerular filtrate rate. So ADH is regulation by ADH. One is whenever there is an increase in fluid volume, it switches off the osmoreceptor and suppresses the ADH release to complete the feedback. ADH constricts the blood vessels, results in the increase of the blood pressure. This increases the glomerular blood flow and glomerular filtrate rate. So glomerular blood flow and glomerular filtrate rate is going to be increased by this constriction of blood vessel caused by the ADH. Second is the regulation by juxtaglomerular apparatus. Okay, juxtaglomerular apparatus, that regulation by ADH, we just saw whenever there is an increase in fluid volume, it switches off the osmoreceptor and it suppresses the ADH release to complete the feedback. And ADH, that is the antidiuretic hormone, they constrict the blood vessels, and this increases the blood pressure. When there is an increase in blood pressure, it causes the glomerular blood flow and glomerular filtrate rate, it increases that also. So when there is an increase in blood pressure, it increases the blood flow in the glomerulus, and also glomerular filtrate rate is going to increase. So the next one is regulation by juxta glomerular apparatus. Okay, so there is a special sensitive region called as juxtaglomerular apparatus, so formed by cellular modification of DCT, and the afferent arteriole at the location of their contact. So formed by the uh, DCT, distal convoluted tubule, and the afferent arteriole at the location of their contact. So this we call it as juxtaglomerular apparatus. So it is formed at the junction of contact, location of their contact between the DCT and the afferent arteriole. So this apparatus is formed by cellular modification of DCT and the afferent arteriole at the location of their contact. So what does this JGA, that is juxtaglomerular apparatus, do? It regulates the glomerular filtrate rate by renin angiotensin mechanism. So remember this. How does it regulate the glomerular filtrate rate? By this mechanism called as renin angiotensin mechanism. So a fall in glomerular blood flow or glomerular blood pressure, so or GFR, it activates the juxtaglomerular cells to release renin. A fall or decrease in blood flow in the glomerulus, blood pressure in glomerulus, or glomerular filtrate rate. So they are activating the juxtaglomerular cells to release renin. Renin is an hormone which is released by them. Renin converts this angiotensinogen. It is inactive form in blood. So it converts angiotensinogen in blood to angiotensin 1 and further to angiotensin 2, which is a vasoconstrictor. So angiotensin 2 increases blood pressure of glomerulus and thereby glomerular filtrate rate. So angiotensin 2 also activates adrenal cortex to release aldosterone. See, these are all the things that are happening at juxtaglomerular apparatus. So whenever there is a fall in the blood pressure of glomerulus or glomerular blood flow or glomerular filtrate rate, so there is going to be the uh, activation of the juxtaglomerular cell which secretes renin. Renin in turn converts angiotensinogen, which is inactive form, into an active form angiotensin in blood, and further this is converted into angiotensin 2. Angiotensin 2 increases glomerular blood pressure and thereby glomerular filtrate rate. Angiotensin 2 also activates adrenal cortex to secrete aldosterone. So aldosterone, what it does, it causes reabsorption of sodium ion and water from distal parts of the tubule. So this also leads to an increase in blood pressure and glomerular filtrate rate. So the aldosterone secreted by this adrenal cortex, they cause reabsorption of the sodium ion and water. So once they are reabsorbed, so the distal from the distal parts of the tubule, so this increases the blood pressure and glomerular filtrate rate. That is how they are going to increase the blood pressure and glomerular filtrate rate by the action of renin and angiotensin 2 especially. Regulation by this ANF. ANF check on the so renin angiotensin mechanism. So the ANF, they check on the renin angiotensin mechanism. So increase in blood flow to the ANF is atrial natriuretic factor. So ANF checks on the renin angiotensin mechanism, which is initiated by the juxtaglomerular apparatus. So which is going to regulate this mechanism, renin-angiotensin mechanism, that is done by atrial natriuretic factor, atrial or auricular natriuretic factor. So the increase in blood flow to the auricles of the heart causes the release of atrial natriuretic factor. So what does this atrial natriuretic factor causes? It causes vasodilation, dilation of blood vessels, and thereby decreases the blood pressure. So ANF checks on the renin-angiotensin mechanism. So they are when the increase in blood flow to the atria of heart causes the release of atrial natriuretic factor. So this atrial natriuretic factor is going to cause vasodilation, dilation of blood vessels, and thereby decreases the blood pressure. So the last part of our discussion, so that is the regulation of the kidney function. So there was regulation by antidiuretic hormone, regulation by the juxtaglomerular apparatus, and regulation by this atrial uh, natriuretic factor, where they are going to reduce the blood pressure. So by the vasodilation of blood vessels, and thereby decrease the blood pressure. So this is how there is entire regulation mechanism is brought about. So the disorders of the excretory system, the last part of our discussion for this excretory system. So what are the various disorders of it? Uremia, accumulation of urea in blood due to malfunction of kidney. So it may lead to kidney failure. Okay, the accumulation of urea in blood due to malfunctioning of kidney, or their inability to remove the urea from the blood. So the malfunctioning of kidney leads to accumulation of urea in blood, that we call it as uremia. So it may lead to kidney failure. So that is what it might lead to. So the accumulation of urea in blood due to malfunction of kidney, we call it as uremia. It may lead to kidney failure. So renal calculi. So there are stones formed within the kidneys. So the kidney stones. So these we call it as renal calculi. Stone or insoluble mass of crystallized salts. So they are insoluble mass of crystallized salts, oxalates, calcium oxalates, etc., which are formed within the kidney. We call it as renal calculi. Okay, so the kidney stones. So now there is a popular uh, show, the Popeye show or Popeye show, however you pronounce it as. You might have seen that. So whenever he has to require a strength, he consumes the spinach and his muscles bulges out. So spinach is very rich in calcium oxalate. So by the rate of consumption of the spinach by Popeye, he should be having very huge kidney stones. Okay, so remember that the calcium oxalate is found more in spinach, and so if our food diet includes more of such oxalate, also it causes this kidney stones or renal calculi. So next time you watch this Popeye show, so remember about the calcium oxalate in the spinach. So don't blindly follow that spinach will give you bulging muscles. It is just a cartoon show. Anyway, so the rate of such consumption will lead to formation of kidney stones. So stone are insoluble mass of crystallized salts, oxalates, calcium oxalates, etc. They are formed within the kidney, and they cause the blockage of this flow of urine and other things. So this we call it as the kidney stones. So stone or insoluble mass of crystallized salts, calcium oxalates, they are formed within the kidney. The glomerular nephritis. Okay, so the glomerular inflammation of glomeruli. So the proteins are secretion of proteins, and proteins are secreted in urine. Okay, so this glomerular nephritis is inflammation of glomeruli. So this is a healthy kidney, and this is a kidney affected with glomerular nephritis. Okay, so they are going to be swollen. So the inflammation of glomeruli, we call it as glomerular nephritis. Okay, so and because of this inflammation of this glomeruli, there is going to be secretion of proteins in urine, and that will be quite harmful if medication are not taken. Okay, the inflammation of glomeruli, we call it as glomerular nephritis. Hemodialysis, this is a method of purifying the blood in the removal of urea in patients with uremia. It is a process of, so hemodialysis is a process of removal of urea in patients with uremia. So the dialyzing unit or artificial kidney contains they contain a coiled cellophane tube. So they are going to contain a coiled cellophane tube. So this is the blood removed for cleansing. They enter the dialyzer. So they are having a coiled cellophane tubes. They are having it surrounded by dialyzing fluids. So they contain a coiled cellophane tube surrounded by dialyzing fluids. So they enter into this dialyzer, and after dialysis, they are supplied back. So the clean blood return to the body. So they are having this dialyzing unit or artificial kidney contains a coiled cellophane tube surrounded by dialyzing fluid. So it has the same composition of plasma except the nitrogenous phase. So the dialyzing fluid has the same composition of plasma except the nitrogenous phase. This helps in removal of urea. Okay, so the process of hemodialysis is the process of removal of urea in patients suffering from urea. So the dialyzing unit or artificial kidney contains a coiled cellophane tube which is surrounded by the dialyzing fluid. It has the same composition of plasma except the nitrogenous phase. It has the same composition as that of plasma except for the nitrogenous phase. So blood is drained from a convenient artery, is pumped into dialyzing unit after adding an anticoagulant like heparin to prevent the clotting of blood. So blood drained from a convenient artery is pumped into dialyzing unit after adding an anticoagulant like heparin. So the porous cellophane membrane of the tube, so the porous cellophane membrane of the tube allows the passage of molecules based on concentration gradient. So the porous uh, cellophane membrane of the tube allows the passage of the molecules based on concentration gradient. So the dialyzer will be having constituents similar to plasma, except with except for urea. Okay, so blood drained from a convenient artery is pumped into a dialyzing unit after adding an anticoagulant like heparin. So the porous cellophane membrane of the tube allows the passage of molecules based on the concentration gradient. As nitrogenous waste, see, this is the uh, coiled cellophane tube. So as nitrogenous wastes are absent in dialyzing fluid, these substances freely move out, thereby clearing the blood. The cleared blood is pumped back to the body through a vein. So the cleared blood is pumped back through the body through a vein after adding anti-heparin to it. Okay, the cleared blood. So before, when they are entering, we add this heparin, and when they are entering the body after dialysis, we are going to add anti-heparin to it so that they regain their clotting ability. The cleared blood is pumped back to the body through a vein after adding anti-heparin to it. We are going to add anti-heparin to it. So as nitrogenous wastes are absent in dialyzing fluid, these substances freely move out, thereby clearing the blood. The cleared blood is pumped back to the body through a vein after adding anti-heparin to it. So kidney transplantation, it is the ultimate method or final method in the correction of acute renal failure. Okay, so the final method of acute renal failure. So you can see here the uh, donor's kidney is taken and it is inserted. The transplanted kidney won't be placed at the deceased kidney level. They won't be placed at the same level. Rather, the donor's kidney is placed at a different level. So the final method in the correction of acute renal failures or kidney failure is the kidney transplantation. A functioning kidney is taken from a donor. It is better to receive kidney from a close relative to minimize chances of rejection by immune system of host. So it is better to receive the kidney from a close relative to minimize the chances of rejection by immune system of host. That is the function of it. So this is the kidney transplantation process to overcome the acute kidney failures. So a functioning kidney is taken from a donor and it is not transplanted at the same region as that of the diseased kidneys. Rather, it is at the lower level they have been transplanted. So it is better to receive kidney from a close relative to minimize chances of rejection by the immune system of the host. So that completes our disorders of the uh, excretory system. Okay. So any doubts or clarification, dear students, you can just let me know. Any doubts or clarification, do let me know.